about echocardiography. So over to you.
Thank you. Afternoon, everyone. I put up a little question there. Who here thinks it is actually not useful? No one, right? But I'm pretty much going to be preaching to convert it here. But then I'll sort of go through a little bit about what we are going to look at the evidence with regards to how useful it is, how the use of echo has sort of blown up over the last few years. Talk a little bit about transthoracic echoes and lung ultrasound. I think that's the field to sort of improving significantly over the last few years. And then I'll give you a little bit of idea, because pretty much most of you are post-fellowship, is that right? So you should be thinking in terms of your subspecialty interests, and if you're thinking in terms of intensive care or thoracics, you need to know how I can get accredited. That's the key bit. Okay with that? Effectivities. Echo, in simple terms, will give you real-time information, real-time evidence with regards to what you're trying to diagnose. So it is not a therapeutic device. We need to understand that. It definitely improves diagnosis. But if you allow a cardiologist to auscultate somebody, what do you think is the percentage that they will miss a significant cardiological finding?
20%.
Yes.
50?
15, 20, about 10, 20%. Hang on, right. So, but you do that, you teach somebody basic echocardiography and ask them to do the examination. They will pick it up every single time the cardiologist misses it. That's the key. It does improve decision making, and does it actually improve outcomes? I will show you a little slide a little bit later on about whether it actually improves outcomes. So, if you look at the different situations where you might use echo would be useful in your day-to-day practice. Remember I told you about how much a cardiologist misses out? I actually did a little study on that one. It's a very simple one. A junior doctor, a basic F1, F2, that level, he was shown how to do a basic ultrasound, and they compared against an experienced cardiologist who had about 20 years experience. And the junior doctor outperformed the cardiologist every single time, pretty much. So it's a very easy technique to learn, and it gives you a lot of reliable information. Our worry always is when we're taking on new things is whether we are able to, whether we'll miss something. That's the biggest fear. I think we need to overcome that and proceed forward. Again, another study, 12 hours of echo. In ICU doctors, it leads to a very high level of competence in detecting basic hemodynamic parameters. In intensive care, one of the biggest things is you have a patient in shock trying to figure out what exactly is happening. It's basic ICU, basic echo will give you all the answers that you need. Again, when you have somebody with an undifferentiated murmur, heart scan, these are acronyms. There are a number of acronyms which sort of came in initially, and they relate to very specific protocols. That's all they are. So that showed a very high agreement rate between students and experts. And then if you use a TTE, a very focused TTE in the older age patients, that does lead to reduction in your 30-day and 1-year mortality across the board. I think that's the biggest advantage with regards to echoes as you go along. How many of you guys will ask for an echocardiography if you're worried about a patient with cardiological disease or any sort of risk factors? Do you know what the evidence base for that is to ask for a preoperative echo? Sorry, you were saying something.
I don't tend to ask for it because it doesn't give that much evidence.
Yeah.
You either think they need to be cancelled and properly worked up, or you just go ahead.
But then you will find out that this is probably one of the commonest things that is asked for. If anyone is doing a pre-assessment clinic, that is one of the commonest tests that they ask for at the end of the day. The actual evidence for that is very limited, even for those with risk factors, and those with cardiac surgery coming in for non-cardiac cardiac disease coming in for non-cardiac surgery. their predictability is only about, the level of evidence is only about 2 beats, nothing more than that. So you have to be mindful of that. But then there are lots of other factors. What you're trying to figure out is, do they have systolic dysfunction or diastolic dysfunction? And diastolic dysfunction is something which goes under the radar significantly. A lot of people, A, do not understand it, and B, is not diagnosed repeatedly. Even when you have an echo, people don't know how to interpret the findings, and that is something which is missed repeatedly. But what you will find is that it's an independent predictor with regards to outcomes. And again, with an echo, what you're trying to figure out is there a left-sided failure, a right-sided failure, or a biventricular failure? And is there any evidence of pulmonary hypertension? Because all these have independent predictors of increased mortality. And that's something, that is what we're trying to pick out from your echo. But then the level of evidence is, as I said earlier, pretty low. Balance of evidence is still not in his favor this thing. They said a resting echo, I think Sue alluded to earlier, a stress echo is probably more beneficial than a resting echo. A resting echo has only a grade 2B recommendation and a level C evidence. So pretty much enthusiasts and experts sort of saying that they need to be doing that. But when you transfer it into other situations, in an emergency setting, when you actually don't know what is happening, echo will change your diagnosis 2/3 of the time. Whereas if you do a TTE anytime from the time of clinic to the anesthetic room, it has a 25% detection rate, and that will lead to changes in anesthetic management. There was a very nice study done in about, I think it was the late 2000s, early 2010, 2011, around that time. This was specifically in fracture neck of femur patients. And what they did was they essentially looked at all these patients coming in for fracture neck of femur management. They essentially put their echo probe on that and then looked for aortic stenosis. And their detection rate was much higher. It modified anesthetic management, and reduction in mortality was much better because of that. So it does give you information on which you can actually act, real-time information on which you can act to actually make your management safer for the patient. With regards to hemodynamic management, as I said earlier, if you have an acute situation where you don't know why the patient's unstable, it does allow you to change your management in about 40% of patients, and it changing the level of postoperative care. If you pick up somebody with acute an illness related to cardiovascular disease, then it does change where you will nurse these patients afterwards. It just gives you a bit more information along those lines. And very, very rarely surgery gets changed, and that is predominantly in cardiothoracic circles, not in non-cardiac surgery circles. Hemodynamic monitoring, very well established in cardiac surgery. I think since about 1990s, it's been used more and more consistently, and the level of expertise among cardiothoracic anesthetists is also a lot better compared to what it was before. But in non-cardiac surgery, it still has a 15% impact. And unstable patients, much more significant impact. And I don't know whether anyone has had experience of intraoperative cardiac arrest. Anyone has had anaphylaxis? No, okay. It is very quick and very easy for you to rule out the reversible, irreversible causes with that. It's actually a very, very quick way of doing it. So that's extremely useful. And for monitoring, if you have a patient who has very poor ventricular function, very high-risk patient, you're sort of managing them, you can intraoperatively, you can real-time monitor their left and RV function. You can assess the preload and contractility in real time. You can look for regional wall motion abnormalities and valvular function. And you can also switch to see the pleural ultrasound for pneumothorax and tamponade. So all these things you can sort of pick out very quickly and very easily with intraoperative echoes. So other big situation where we tend to use it a lot is emergency. And again, I think if you go to a trauma call nowadays, pretty much everyone gets a fast scan very, very quickly. And that allows you to diagnose a lot of things very quickly instead of transferring these patients back and forth between the CT scanner and back. Fast protocol is very well established. Again, in the emergency room, hypertension of any cause, you have a 4 in 5 chance of getting the right diagnosis. And you see a patient with a hyperdynamic LV, it is very, very specific for septic shock. If you see those images on the echo, you will be able to pick out very quickly, and it is very easily learned with regards to doing that. And you can use it to sort of differentiate between other cardiac pathology like chest pain, cardiomegaly, or is there a pericardial effusion or pleural effusion. All those things you can pick up fairly easily. Neurosurgery is a 27% incidence of PFOs in patients. Now, if you did not know about that intraoperatively or preoperatively, and you put them in a sitting position, it's an absolute contraindication to the sitting position. So, with an echo, you'll be able to pick it up. Again, to manage, it's to monitor these patients for air embolism. Again, echo is extremely useful, but very few centers will actually use it. And you can refine the position of CVP catheter tip to allow the aspiration of air, because you'll be able to see the bubble of air very clearly exactly where it is within the veins or the RA, and you can actually refine the position of CVP there. Vascular anesthesia, you can use it as an intraop monitor, because all these patients, if they have vascular, they're coming in for vascular surgery, they'll have some coronary disease as standard, so they will have coronary risk factors. Endovascular repair is very interesting, because that for me, especially thoracic endovascular repair, that for me is a very good indication for a TOE intraoperatively, because it's very easy to visualize the descending thoracic aorta on the TOE, and you can select the landing site. You can you can guide the correct placement of a guide wire. So if the guide wire is not coming in the right position, you can very easily tell the surgeon, who will modify his technique to make sure that they can be able to do it. And post stent landing, it is very sensitive to detect any leaks in there. So it does give you a lot of advantages. That's what I'm trying to sort of get the message across. Obstetric disease, it is sort of useful in a number of situations, and TTE is usually the modality of choice we'd use in that position, because the patients sort of tend to go a little left lateral down there. It makes your TTE much easier to do. It sort of helps. ITU, I don't really have to say much about this. It is an expanding field. A lot of consultants are starting to use it significantly, and the impact on therapy and management is significant. Almost 50 to 60% of them will have some impact on treatment. It is safe, it is portable, it is easily done. It allows you to have a rapid assessment of function and structure, and it is extremely easy to learn with 4 chambers and 2 tubes. That's pretty much it, really. Okay, so let's go to pass on. Then the question rises with regards to what do you use, whether you use a TTE or a TOE. That's the question. I think a lot of the time you will be restricted by the fact that you will not have access to a TOE probe. But then if you speak to your cardiology colleagues, there will be a TOE probe in every EGA. So it is still possible to access a TOE probe if required. And if you think that that is going to help with regards to your management of the patient, that is something you can easily get. So between the two, early on, TOE was much superior to TTE, because the quality of the images that was got with the transthoracic probe was much inferior compared to a TOE probe, because the TOE is much closer, your penetration is better, and you're not the lung doesn't come in the way as you speak, and that's a big advantage with regards to the TOE. But then with development in technology, that has sort of completely disappeared, except for really big patients where you do not have an echo window at all. The rest of them, you can pretty much get as much information from a TTE as you can from a TOE. In certain situations, TTE will actually be better than TOE, and that is because of the distance. There are certain structures which you can't do well with the TOE, but you can do well with the TTE, and the reverse holds true as well. And it's extremely sensitive, specific, and has a positive predictive value of 97%. So pretty much, yeah, on balance, everywhere, on balance, if you look at it, the technology has developed so much, the expertise has developed so much over the last 10, 15 years that it has become pretty much part and parcel of our day-to-day practice. That's how things are going at this point of time. So moving on, I'm going to talk a little bit about, give you a little idea of basic echocardiography and basic lung ultrasound. How many of you actually do echo and ultrasonic, lung ultrasound in your day-to-day practice, or are learning, or actively learning? Do a little bit. Okay, a few hands. Hope that will give you a bit more information so that you'll all be able to learn as you go along over the next 2-3 years. I think the ST 567 is a period where you can very easily get so chilled out, relaxed, and yeah, exams over, it's all well and good. But then this is the period where you should A, decide on your subspecialty, and B, learn new skills, keep learning new skills. That is extremely, extremely useful. And I think having echo and lung ultrasound is an extremely valuable skill to have when you go into any sort of job in a couple of years' time. So, what did earlier as I said, there are just 4 chambers and 2 tubes, literally. That's what you're looking for. And there are, with both TOEs and TTEs, there are only few echo windows that you need to know about. Transthoracic, it is your parasternal echo window, your apical window, and your subcostal window. Those are the 3 ones. With the TOE, it's just 3: upper esophageal, mid esophageal, and your transgastric. Those are the 3. So it's actually very easy to do those images if you have a structure in place of how to do them. So the first one is, this is probably the commonest one which every one of you would have seen before. So it's a parasternal long axis, and the thing you always look out for is the dot. If the dot is on this side or this side, that will determine where you place your transducer position marker. Okay. Normally, cardiology have a standard technique, and that is they put it, the dot is over there. So have you guys seen the probe? It has a little dot in there, yeah? So you just need to make sure that that dot is on that side. Once you've done that, then second to fourth intercostal space, just to the left of the sternum, you point, the transducer point marker will be towards the patient's right shoulder. So you just sort of point it towards the right shoulder. And then you should be able to get a very nice image of the parasternal long axis view. And the structure you will get to see are the left atrium, the mitral valve, the subvalvular apparatus with the papillary muscle and the chordae tendineae, the outflow tract, the aortic valve, and the ascending aorta. And what you see in there is your right ventricular outflow tract. And sometimes you'll see a little structure here. That will be the descending thoracic aorta. Okay, so it gives you lots of information. So anytime you see in those echo images, what do you mean by a long axis is where you can see both the inflow and the outflow in the same view. That's all it is. It's nothing more complicated than that. Okay, so it's a very simple view to get, and it gives you pretty good information about whether you can put some color across here to see if there is any mitral regurg. You can put some color across here to see if there is any aortic regurg or stenosis. The thing you look out for stenosis is when you put color across this, you will see a lot of turbulence here. You'll see a very mosaic pattern. And the other thing is, normally the leaflet will be very thin and it's not easily visualized. But if you're able to see the leaflet very easily, that is always a dead giveaway that aortic valve is abnormal. So the thing you need to sort of learn is quantitative assessment is not going to be the aim of the game here. What you need to understand is to be able to pick things up qualitatively. Is it normal? Is it abnormal? That's all you want. And that will, you sort of, as you go along, then you can sort of add things onto it to make it better. So that's the first view you get. On the same position, the transducer remains in the same position. Now you just rotate the transducer about 90 degrees with the position marker towards the left shoulder, and that will give you your parasternal short axis. And then with the short axis, you can actually tilt a little bit up and down, and that will mean you will be cutting it a little bit higher and lower. The base of the heart is where the valves are, the AB valves are. So if you go a little bit higher, you get to see a little bit of the mitral valve, the undersurface of the mitral valve as it comes along. As you go a little bit lower, you will tend to see more of the apex of the heart. Okay with that? So this one is a very good view overall. This is extremely good for assessing with your eyeball contractility, any regional wall motion abnormalities, and by that token, if there are regional wall motion abnormalities, you will know where the lesion is with regards to the coronaries. So if the septum is completely akinetic, then you know that it is most likely to be the RCA lesion, or could be a circumflex lesion. So one of the two, depending on what the coronary anatomy is going to be in that patient. But then this is one view which will give you an overall picture, and that's extremely useful. And very quickly you do the long axis, turn around, short axis, you have an overall picture of how the left side of the heart is very, very quickly indeed. Okay, so the next apical window I talked about, the next one I talked about was the apical one, so which is pretty much at the, ideally the patient needs to sort of roll to the left a little bit. That will improve your imaging better. And then you place it at the, what is that? At the apex beat, yeah, at the apex beat, and aim it towards the patient's right shoulder. Now, this will give you an overall picture with regards, so pretty much the ultrasound probe is there, so it will give you a composite view of the entire heart. A lot of the time you see this, what does that look to you? Sorry, it looks like a septal defect, but it's not, because that's a very, very common artifact in an apical four-chamber view. Okay, so because of the distance from the probe to the image, and it's sort of been intervened by a number of these structures, there is loss of signal there. So that's the reason why you always get it here.
Could you put color across that to look for that?
You can, but then if it is a low flow septal defect, you really will not see much flow across. So very difficult to confirm whether there is a PF or whether there is a PF or an ASC or not. The way to confirm it is always with contrast. So either bubble test is the only way to do it. It's the only sure way of doing it. The one other thing is, when you're sort of learning these little tricks of the trade, is when you're doing these images, never make a diagnosis based on just one view. And that's a dictum which we tend to follow all the time. If you find something is abnormal, go ahead, look at from the other view, look at some other view to corroborate or confirm your finding. So when you do it in another view, it will either confirm your finding or it will refute your finding. So that is always the way you make your judgment or diagnosis. So with the apical four-chamber, it's a very good view of the heart, and that's the left side, mitral valve, the left atrium, the right atrium, tricuspid valve, and the right ventricle. And if you look at it, the apex is usually formed by the LV, but then when the RV sort of becomes dilated, hypertrophy, pushes through, then it can form the apex as well. So it depends on that. And then you sort of move a little bit in and out to sort of slide it across to focus more on the left side or the right side. And this is a very good view to pick out all your Doppler parameters. So you can measure inflow, you can measure the movement of the, for diastolic function, you sort of do what is called as E prime and the S prime. So those things, tissue Doppler imaging, that's what it is. So you sort of do some of those. You can measure velocity across the tricuspid valve, which is used to predict what your RV systolic pressures are, so whether the patient has pulmonary hypertension or not. So if you can use all those things, well and good, but very simply just putting color across there will tell you whether there is any MR or TR. And overall, you will have a picture of how the LV is contracting, how the RV is contracting. And that's good enough in most instances. Right, the next one is the third window is the subcostal window. So you place the transducer below the xiphoid process in a transverse orientation, and you sort of try to get under the xiphoid process to obtain the view. And you get a modified four-chamber view, and that's how it will be. So it is still the LA, the mitral valve, LV, RA, tricuspid valve, and the RV. And part of this will be the liver sort of coming in the picture. And then if you sort of focus on this and then adjust your angle a little bit, you'll be able to see the IVC sort of entering into the RA, and you can ask the patient to sniff, and collapsibility is used to check how your RA pressures are. So that's a very simple way of doing it. Okay. So let's try. Now it's going to be the, just got a few images just to see if it sort of works. Okay. So those are the kind of images you will get with regards to a parasternal long axis view. And As you can see here, the aortic valve is actually not very easily seen at all. And it just looks to be really, really thin, and you have to strain to see it. But then if it is stenosed, what you will see is a lot of calcium in here, a lot of calcium here, a lot of calcium there, and the aortic valve will be very easily seen. And the opening also will not be normal. So these are something which you can sort of pick up very easily with just your, with just eyeballing. Just got a few echo images, so sort of gives you an idea of what the kind of images you're going to see. Okay with that? So that's your, which view is that? The parasternal short axis. And is it the basal or the mid parasternal short axis? We see the mitral valve. So, sorry, I need to go back. You see the mitral valve, so it is what? It's the base. Okay, the base of the heart is where the AV valves are. Remember that. Okay, so when you see the mitral valve cutting across, then it's the basal view. When you see the papillary muscles, that is your mid parasternal short axis. Okay. Now the apical four chamber. I think very rarely you get images as clear as this. I have to warn you on that one though. So it's actually a very good view of picking out. Sorry. I want to ask you one thing. Yeah, do both. Just play the video. It's not on a loop, unfortunately. What is that? Anyone knows? What's the extra point?
Some band.
Yes. Moderated band. It's a common thing that you find within the RV, so it's nothing abnormal. So it's something that is commonly seen. The other thing you always look out for is the relative size compared to the LV to the RV. The RV is 1/3 of the thickness of the LV, so that is something which you will know with the shape very quickly whether it is thickened or not, or the RV is dilated or not. So, and again, the size is actually smaller than the LV most of the time. So that's something you can look out for. Yeah. So, you want to check out a few images. What do you think is happening there? Mitral regurg. Can you say whether it's mild, moderate, or severe just by eyeballing?
Severe because it's covering the whole length of the LV.
Yes, but then what are the first thing you check out before you make that assumption? The first thing you check out is this. If you reduce the velocity, even a mild MR will think as if it is severe. So always know what you're looking for. And my advice would be never try to quantify things when you're actually learning it for the first time. There are very specific ways of quantification, so that is for later. Sorry. Yeah. Now this is a different one. Have a look at this. Now, what do you think is happening there? Press again.
Play it.
Play it again. Yeah. What is happening there? It's a slightly different image. It's not the standard. There are a couple of findings in this one. Can anyone point that out to me?
It's a small pericardial effusion.
Yes, there is a small pericardial effusion, which you can see all along.
Is it two-chamber?
It is more of a two-chamber view, but it is more of a long axis view, apical long axis.
And the jet
That gives it that.
wall of the-
Yes, but which direction is it? Is it anterior or posterior? Once more. What is this structure? Aortic valve, and the jet is going. Jet is going
Almost.
posterior. It is posterior. the way you sort of remember that is aorta is usually anterior. Aorta is an anterior-posterior structure. It starts anteriorly, loops with the arch, and then goes posteriorly. So aorta is an anterior structure. And the leaflet that is attached to the pretty much to the aortic annulus is your anterior mitral leaflet. So that is, and if your jet is going away from that, it's a posterior jet. That's how it is. Okay? Right. Go on to the next. This is a slightly different one. I'm just going to show you a few different images. Now, what do you think is happening there? This is a TOE. This is not a TTE. Okay? Give you that information first. Now think about
Can
it.
you just orientate to what we're looking at?
Okay. Fine. Good point. So with the TOE, it's just the images are straight opposite of that. Can I hold on? Let me just go back. Now, see this. This is your apical TTE image, correct? With the TOE, because the esophagus is posterior, the first chamber you always see is your LA, right? So pretty much you just flip it on its back. That's your TOE image. That sort of structure very nicely. That's why I took the video anyway. Let's go back. Yeah. So that's your LA. That's your mitral valve. That's your outflow tract, and the aortic valve is sort of coming in there. And this is the right side of the heart. Something big sitting in the LA, isn't it? So it's an LA tumor. Whether you can say whether it's a big tumor or not, histology have to tell that, but it's most likely an LA tumor. So this is the kind of images you get if sometimes very nicely. So what about this one? Again, a TOE image. As I said, this is pretty much you flip your apical four-chamber view on its back, you get the TOE image. Okay? So that's the left side. This is the right side. Massive LA. Massive LV. So, and this, just by looking at it, I can tell you the annulus is very dilated. Okay? So, this doesn't require a lot of training or teaching. It's something you see a couple of times, see a few normal ones, you can pick these things up very quickly. This is what I mean by qualitative assessment, qualitative diagnosis rather than quantitative diagnosis. Okay? The next one. Again, this is a TOE. You saw the parasternal long axis, right? Very similar. That's your LA, mitral valve, aortic valve, and the ascending aorta. And what do you think is happening there?
The dissection flap.
That's a dissection flap. That's how a dissection flap looks. Okay, so that's something flipping about significantly in there. All right. Now, with the TOE, it's very easy to look at the lungs. If anyone of you has done any lung ultrasound, when you do the costal view, this thing, that's what you will see. Collapsed lung, a pleural effusion. So that's what you tend to see. But then with the TOE as well, you can actually see that. It's a very nice way of looking at it. But then the way you decide which side it is, though, which is right or left, is the question. Anyone knows? No, you said look for the liver. You have to be transgastric and then turn around. Yeah, you can still look for the liver, but then this will be at a much higher level, so you won't be getting the liver in view. Any ideas? You look for the claw. The claw is pointing to the right, it's a right-sided effusion. Pointing to the left, it's a left-sided effusion. That's the way you do it. Okay? So remember we talked about the parasternal short axis view. This is very similar. Yeah. But then what do you think is happening with this ventricle? Just looking at that ventricle, what do you reckon? It's not contracting at all, isn't it? So you would be worried about a patient who's like that. That's something which is very easy to pick up. And this, if you look at it, the septum is not moving at all. The inferior wall, the lateral, and the anterior wall are severely hyperkinetic. according to me. Okay, this pretty much is not moving at all. All right. So as a quick overview of a little bit of images with regards to how you get those images and how you can sort of interpret them with a few examples from both TT and TOE. Okay with that? Yeah? Good. Okay. Right. Going to do a little bit about lung ultrasound as well. First thing is, I'm not an expert on lung ultrasound. Recently okay with cardiac echoes, but not. I'm still learning on this front. This is something which is still new for me, so bear with me. But I'll give you the basics with regards to how you can do the basic images and how you interpret things, and that's the key bit, isn't it? It's always interpretation takes time rather than getting the images. Getting the images is usually the easy bit, and every one of us will pick things up fairly quickly. But then interpretation is one which takes time as you sort of do more and more of them. So two basic things that we tend to do is a longitudinal scan and an oblique scan. An oblique scan is within the rib margin so that you get a longer view of the pleural line, whereas a longitudinal scan, you just see the two ribs in there, and then you sort of get a little window through which you see your lung through that. That's what you're looking in for. And where do you put the probes on? So there are a couple of different ways of doing it. One of them is your parasternal line, anterior axillary line, and your posterior axillary line, and then you sort of divide it into, along the nipple line, you divide it into two. So you tend to get 1, 2, 3, 4 zones. And this is very useful in intensive care patients who are supine, sit there, you don't have access to the back, and that's something very easy to do, and you will get a lot of information you need from lung ultrasound on this one. The other one is you sort of put your fingers across the chest, and then those red points are the points where you put your probe down. So that anteriorly 2 points where you put the probe down, and then posteriorly is a single point. Behind the posterior axillary line, sort of in level with the level of the nipple, is where you put the probe down. So that's a 3-point positioning with regards to trying to get the images across. Okay? But then when you put the probe on the lung, what do you actually see? That's what you actually try to get. So a longitudinal scan will be an image like this. Apologize for the quality of the image, it's not the greatest. And an oblique scan, you'll tend to see a lot. The pleural line will be much nicely seen. What has been the biggest, with regards to lung ultrasound, why was it not developed that earlier on? People never used to do lung ultrasound before. Why was that? What was the thinking behind it? If you have a fully aerated lung, can the ultrasound this thing penetrate that is the question. It doesn't. So because the lung is fully aerated, you really can't see the lung parenchyma. People never thought that it was actually useful. But then the way it is sort of developed is you look for artifacts. And by looking at artifacts in a very systematic way, you actually get a lot of information about the lung. And that is how they are doing it nowadays. Okay, so that's your rib margin, and that's your pleural line. All right, and that's your pleural line in a longer line. That's what you look out for. So the key thing, when you put it on the longitudinal plane, this is what you look out for. So you have your rib there, you will have lots of ultrasound images there. So it will just be a black opening in there. But then the gap between the two is where you actually have some imaging of your lung parenchyma. And that's where you look for the pleural line, and it will be just sort of sliding along with respiration. That is what you look out for. And there are a number of ways of actually figuring out, and there are something called A lines, B lines, things like that. We'll come to that in a minute. I'm going to play the video, please. So just sort of an idea of how it looks like when you actually put it in. Okay, so that's how it will look like. So you have the rib margins there. That's your pleural line. And you can see that it is sort of gently moving a little bit. Can everyone see that? Okay, good. So if you put M mode, do you know what M mode is? Motion. So a single line of ultrasound, this thing across the line. Sorry, what
I
is
was
it?
just going to say it drops a point when you.
Yeah. So you're essentially sending an ultrasound beam across the single line. That's all it is. So if there is lung sliding, if the lung is moving normally, you tend to see what is called the seashore sign. So you have this tissues are all the sea, and then beyond the pleural line is just nothing beyond, because there is a lung underneath that. That's the seashore sign. Okay. If you do not see much beyond, then if there is no lung sliding, and this is essentially what you see with the M mode. Absolutely no differentiation between sea and sand. It's just a stratosphere. So it's called a stratosphere. So the little points with regards to what you look out for, and I'm just giving the basics, as I said. So things you look out for in lung ultrasound are A line and B lines, and a combination of that gives you a lot of the information that you look out for. If the lung is actually collapsed, then it behaves like the liver. You can actually, the ultrasound beam penetrates it, you can actually see the lung parenchyma directly. So, but before that, there will be different stages at which your lung will be consolidating. So you will have increasing amount of air or decreasing amount of air and increasing amount of fluid within the lung, and that's where the difficulty is with regards to it. And that's why they use these A lines and B lines to figure out what exactly is going on. So A lines, because air reflects ultrasound, you have a beam. It essentially comes from there, hits the pleural line, comes back, but then it will reflect back, so it will keep doing that. So what it is essentially a reverberation artifact. So it doesn't mean that there are multiple pleural lines here. It just means there is one pleural line. Because there is strong reflection from the pleural line, you tend to get these. If you look at this, same distance, same distance, same distance. Okay? So it is just a reverberation artifact, and that pretty much implies a normal lung, or it could be a pneumothorax. We need to figure out what exactly it is. What about B lines? B lines are essentially mean there is an increasing amount of fluid within the lung parenchyma. That's what it means. The proportion of it is something which we do not know. Up to 2 B lines are actually normal, especially in the basics. But then they have very specific characteristics. They have to arise from the pleural line, and they are vertical hyperechoic lines. See this? That's what you're looking out for. Okay? And they should extend to the depth of the image, and they called us, previously used to be called as tail artifacts. But then after a big meeting between the different groups, the nomenclature was sort of standardized. So now they call A line, B line, and the rest of the stuff. Okay. Again, that's B line, starting from the pleural line, extending all the way through. Yeah, and it moves with lung sliding, and it has to erase the A lines. That's the characteristic of a B line, and it implies what we call as interstitial syndrome. Okay, and interstitial syndrome can be in a setting of edema, pneumonia, or fibrosis. Any of those things can cause this finding with regards to the number of B lines. So anything beyond 3 is abnormal. That means the lung has increasing amount of fluid in it, and it's called as interstitial syndrome. Okay with that? But then once you start getting consolidation, the thing with lung ultrasound is you cannot diagnose structures which are at depth. You can only diagnose structures which are superficial, right, very close to where the pleural line is. So if there are peripheral consolidation, you can actually penetrate very easily, and you can actually get a very good image of that. And this is what I said earlier. Once the lung becomes solid, you visualize it just like any other solid organ. And that's your diaphragm, the liver there, and that's your collapsed consolidated lung and pleural effusion on the side. Okay? But then the other thing where it is actually very, very useful is to rule out pneumothorax. And it's as good as a CT with regards to diagnosing pneumothorax. It takes less than a minute, and the features you look out for are no sliding, no B lines, no lung pulse, and you will see a lung point. So a little flowchart to help us. you check out whether there is sliding or not. If there is lung sliding, when you put it at the apex, in a patient who sort of sat up, you can see lung sliding. There's definitely no pneumothorax. You can rule out in a fairly certain way very quickly that whether it's a pneumothorax or not. But you don't see any lung sliding, then you look for B lines. If there are B lines, then it is more of interstitial syndrome and not pneumothorax. So again, no pneumothorax. But if there are no B lines, you look for the lung point. The lung point refers to the point where your parietal visceral pleura are sort of separate out. So you have a sort of, when you have pneumothorax, they are separated out, isn't it? So and then it's sort of joined back up at some point, and that is the point you look out for with the ultrasound, where they sort of join back together. So you look for the lung point. If there is a lung point, there is pneumothorax. If you can't see the lung point, sometimes it will be hidden beneath or something, then you look out for the lung pulse. It is just the oscillation of the lung with the cardiac beat. That's what it is. You look for that. If you look at that, then if there is lung pulse, then there is no pneumothorax. It's a very simple way of actually ruling out or in whether there is pneumothorax or not. Yeah.
The lung pulse, could you, I mean, we actually saw it yesterday on somebody that got really poorly lungs, but quite low down. Can you see that at any point in your ultrasound of the lung? Or is it typically, I mean, I guess
Typically more towards the basis is what you have to sort of come down a little bit to be able to see that, yeah.
that's pretty much a normal finding.
Yeah. Okay, so any new technique that sort of come in, there is usually an inflection point beyond which things sort of become far more useful and far more regularly taken up. If you look at smartphones, there was an inflection point about that, would you say? Yeah? After that, it's just sort of taken off. And that is how things are with regards to goal-focused echocardiography as well. So for that to sort of take off completely, it's already started happening. But for people like you, SC567s, to be coming out at the end of your training with your echocardiography skills, your lung ultrasound skills, will need a little culture change. The thing we need to remember is anyone can perform it. It's about pattern recognition. It's just like ECG, you can learn it. And you are not a diagnostic cardiologist, so don't have to worry about that. You use it to answer clinical questions in real time, and we have to overcome our fear of missing something. That's our biggest issue. But then we have to remember misdiagnosis can lead to harm. That's why we need to make sure that we sort of learn it in the proper way and then still use it, because it's definitely better than clinical, better than an experienced cardiologist for that matter. So with regards to how you go about it, with every, you guys have seen the expertise pyramid before? Especially with regards to echo, you have your feel, fit, your different acronyms for your level 1, your emergency one, and then you have your level 1 where you just do your basic standard views, recognize abnormal versus normal, diagnose common abnormalities, and then you can sort of understand what it sort of tells you in that sense. So most of us should be within this region is the aim as we go along. But then when you are doing specialist stuff, say a cardiothoracic anesthetist, for example, should be along that level. Whereas this is reserved for cardiologists. I think they are specialty. So how you go about it, you need to train yourselves and you need to get accredited. Training is essentially acquisition of knowledge, whereas this takes a lot more effort. You need to achieve competence and you need to be recognized as competent by a responsible professional body. And suggested pathways are numerous. Both the EACVI and the BSc have specific pathways, both basic and advanced, with regards to both the BSc, the EACVI, or the National Board of Echocardiography in the US. So all those things are available. I think the UK-Australian model is very simple in that sense. You can do a level 1 BSc accreditation that includes TTE, lung ultrasound, and basic TOE. You have the very specific ITU remits one there, the FICE, the QSIC, the field fit. It essentially involves a little course plus a bit of experience with cases, and that's what it is. Whereas if you go down this route, you can do your TTE accreditation, TOE accreditation, or the acute cardiac care or the critical care accreditation. There is one separately, and that has pretty much exactly the same requirements as a TTE, plus specific things about in your ITU and your abdominal ultrasound. So those things are there. And this involves a bit of effort, exam, plus cases, plus you have to submit a logbook. And nowadays, you are asked to come in and then show that you can actually acquire those images. Because where people used to sort of get through was images were always sort of centralized in an image pool, and they would always be able to take those images and then send it off as, yeah, I've done it. But then it doesn't really work that way. But then they are asking people to sort of come in and actually acquire those images nowadays. So that's the way to do it. I did say earlier, whether I'll sort of touch upon a little bit about how it actually improves outcomes. This is relating to cardiac surgery. I apologize for that. The number of operations over from 2003 to 2013 for the last 10-year period, about 40,000. That is your predicted mortality. You can see that. That's supposed to rise. But actual mortality has come down. And for that, the single biggest reason is the use of echocardiography day in and day out with regards to cardiothoracic centers. You'll be very surprised that any cardiothoracic unit in this country now will have so many members who are TOE accredited or TTE accredited or combined. So that's how it sort of impacts and changes your outcomes. So in summary, sorry we've been running a little bit late. There is widespread consensus that it is very, very beneficial. We don't have a lot of outcome data, but we can be, with regards to the more we use it, the better we become. That's the thing. Beware the PA catheter. But then, for me, I'll always argue the opposite way. Even with the PA catheter, if in the right hands, it actually gives you a lot of information. And with that information, you can actually make a difference. And that's the key bit. And it's a technical skill. It needs education, competence, and quality assurance. But the limiting factor for a lot of us in a DGH setting would be availability of equipment and a trainer to sort of train you. But if you do have those facilities available, use it to the best of your abilities. That would be my advice. Okay. Any questions? Short silence.
Thank you very much, Ram.
Okay.
So guys, that's the end of your study day. Hopefully it was useful. It's given you an idea of the various areas in vascular anesthesia. What I would like is if you could just all fill your feedback forms before you run away, and just fold the top corners so the forms stay together, if you know what I mean. Ram, thank you very much. He's come in just before his ITU on 4 shift, so I really do appreciate